I wanted to welcome you all back to the PainExam Podcast. Today, I have the pleasure of being joined by Guy, or Dr. Guilherme Ferreira Dos Santos, out of Spain. Welcome, Guy. How are you?
Thank you very much. Thank you for the kind invitation. It's a pleasure to be here. Thank you.
So Guy has, oh my God, the best posts on LinkedIn I've ever seen for pain management, for ultrasound, for regenerative medicine. And I've been following him for a long time. And then I realized we know a lot of people in common. In fact, we're going to be both presenting together in the Pain Expo in Dubai in April with
Yes,
Pradeep
indeed.
Bayani. And I figured, well, before meeting you in person, it would be nice to do a podcast. So first of all, welcome again. And can you? I read about your I guess your history or your education and the education that you currently work on and the research. Can you just give us an overview of your training that took you from Portugal to Spain to Canada to the U.S. and
So yeah, sure. So I'm originally from Portugal. That's what I did my med school, and then I started PM&R training there. And then while I was training in PM&R, I got interested in pain medicine. So I started to look up opportunities to develop, interventional pain medicine skills. And at the time, I was awarded a scholarship to go to Mayo in Florida to train with the team of Mark Hurdle, who's an interventional pain specialist there. So I went there. I went there twice. Overall, I stayed for about a year, and this was during my residency. And then I got started while I was studying at Mayo. And then I got so interested in pain medicine that then I wanted to pursue further training and to do a fellowship in pain medicine. And so I looked up a few options. I talked to a few people, and then I ended up in the University of Toronto in Canada, and I did my fellowship in interventional pain medicine in Canada. And then while I was in Canada, the University of Barcelona was at the time setting up new infrastructure to build a fully dedicated interventional pain medicine clinic at the university. And I'm an academic, so I like to do research. I like to teach. I like the academic side of medicine. And so they called me when I was just about to graduate from my fellowship, and they asked me if I wanted to come back to Europe and to eventually settle down in Barcelona, which is to me, very close to home. So I said yes, and so I've been in Barcelona for about 2 years now. I'm 100% dedicated to interventional pain medicine, and most of my work is on regenerative medicine and ultrasound-guided techniques, as you said. And I take great pleasure in teaching fellows and teaching our residents, and then in trying to advance our program and then to do cool stuff, I guess. At least to me, it's very cool stuff.
That's exactly what piqued my interest because anybody could show an ultrasound guided injection of the shoulder, but I like your angle and you're also doing hydrodilation and the regenerative medicine. And really, if you don't follow him on LinkedIn, I think you should. I mean, you're missing out because there's a lot of cool things you're posting. And I think regenerative medicine is at its infancy. I mean, there's so much we still have to learn. And it's surprising that there are still people who aren't offering their patients this. And they're not really, I think there's an intimidation factor that people have before they do their first case. They just don't really know what it's about, so they're just hesitant. But when you realize what it's about, it's safer and in some ways easier to do than the regular stuff.
I agree. I get a lot of pushback from some colleagues that regenerative medicine still does not have enough evidence to support it. Or that everything we do is sort of experimental. I don't know if you face that in the States as well, but I do face quite a lot of pushback here in Europe from some people, and it is somewhat true that part of the literature is still a little bit all over the place. But I usually tell people, if you pick the best literature, and when I say best, I don't mean the literature that has only positive results. What I mean is, if you pick the best papers, the papers that are more solid, the papers in which the methodology was best employed, most of those tend to show either similar or superior results to most of our I would say, conventional interventions in interventional pain medicine, meaning steroid injections and so on and so forth. And so to me, the question comes down to, if I have an intervention that is at least similar in efficacy to the conventional treatment that I am able to offer, but that has none or almost has a lot less side effects, potential side effects than the conventional treatments, to me, it's a no question, because if I can do a tendon PRP injection, which either works to the same level as a steroid injection, or depending on the literature you read, may work a lot better on the long term, and it has almost zero side effects, no risk of rupturing the tendons, no risk of hyperglycemia in the days after the procedure if your patient's a diabetic. It's a no-brainer to me. Obviously, then cost comes into the question. But if we're just talking about one procedure versus the other, and we're taking out the money out of the equation, to me, regenerative medicine should always be the first option for my patients. And in most cases, it is, even in the cases where patients have to pay out of pocket for the expense of the regenerative option.
I agree with you 100%. And when you're talking about this, it reminds me of, and maybe the data has changed, but there's been probably a few months since I reviewed it. I like the example of the Achilles tendinopathy, which, according to the large meta-analysis that was done like 2 years ago, I think, it doesn't work. But I've seen it clinically work. And if it was my Achilles tendon that had an issue, I probably would still try the PRP prior to any other type of injection, despite this large meta-analysis saying it doesn't work. And I think, first of all, one thing that you didn't mention, but it was probably the case for many of these studies, is there's no standardization, right? Like, I mean, your PRP may be a little different than my PRP. So when they're looking at that, I think that's a big part of the puzzle that you need to consider when interpreting the conclusions of these studies.
So totally in agreement, and I think the first step would be to your point, and a few organizations have tried to come up with standards in how we should classify PRP, and it is true that a lot of the Q1, let's call them more serious journals in the areas of pain, orthopedics, sports medicine, are trying to define some standards on, if you want to publish a paper on PRP, these are the minimum standards of classification that you have to meet in order for your paper to be able to be published. And I think that will be the future, because again, we do lack a lot of standardization in not only PRP, I mean, any sort of orthobiologic intervention. Prolotherapy would be the same thing. BMAC would be the same thing. MFAT would be the same thing. So it is true we lack a lot of standardization, and I think the way forward would be to standardize a classification or 2 or 3 classifications that people worldwide would need to meet, not only for research purposes, but also for clinical purposes, meaning anytime I do a PRP on the patient, I should get a cell counter, an office-based cell counter, and I should check, my platelet count, my leukocyte count, the efficiency capture of the technique that I'm utilizing. And then this would also, I believe, lead or push the industry to develop better technology and better equipment. Because for the past few years, it was relatively easy for a company to come to your office and tell you, listen, I have the best PRP equipment out there. We did our in-house study, and the results show that our PRP concentrates 15 times, and it's better than all the other ones. And because you don't have a cell counter in your office, because up until 2 or 3 years ago, it wasn't a big thing. There weren't even a lot of companies offering portable, small cell counters. You'd be inclined to buy the product.
Sure.
But nowadays, what I notice here in Europe is a company comes to me and says, I have this PRP preparation kit. It concentrates 9 or 10 times baseline, and then I do a few numbers on my own patients, and then it is true that sometimes the equipment may concentrate 9 or 10 times, but other times it concentrates 2 or 3 times baseline. So the margin of error of the equipment is not as small as companies like to claim sometimes.
Sure.
And patients are very different and the same patient if you pick the same patient in 3 PRP sessions, their platelet count will be different. And so it's such an issue that in my mind it is very, very easy for results in clinical studies to be distorted either positively in some cases or negatively in other cases.
I think that makes a lot of sense. Um, so I'm going to rewind a bit. So you bounced around all these different countries, and you've had the opportunity to see the healthcare systems. So with respect to pain in general, what's your impression? I mean, you saw the US system, and our healthcare system is kind of a mess, like many other countries, I suppose. But um, the Canadian system, I worked in Canada. I've done a lot of teaching there, so I know how that works. More of the private practice side. I have not seen academic Canadian medicine, but I've done some private teaching in the clinics in Canada, so I understand how pain management is there. But what about Portugal and Spain?
So in Portugal and Spain, in comparison to the US, for example, healthcare tends to be mostly public, meaning for big or chronic and difficult to manage conditions, most people tend to get their care at the public hospital. Those would be most academically affiliated hospitals tend to be affiliated to public universities. Things are starting to change somewhat, but most people still get the vast majority of their care in the public center. It has some advantages. It has some disadvantages. Advantages being if you need a heart transplant or a liver transplant, you get it for free. You don't have to pay any co-pays, any out-of-pocket, any healthcare insurance fees. You don't have to pay anything for that. Um, on the other side, I mean, waiting lists tend to be somewhat longer depending on the institutions comparing to private practice in the US, for example. You don't get as much. So from my perspective, if you're someone who's inclined to do research, for example, it's much easier to get the funds you need to get or you want to get to run your research in a place like the States. Or even in a place like Canada than it is to get in Europe. So in Europe, we face a lot more obstacles in with regards to getting our research properly funded to run the trials we want to run. On the patient level, it's hard for me to analyze because I've worked in a lot of institutions, and a lot of institutions, even within the same country, they work very differently.
Right.
I would say with regards to the States, I like the phrase of a colleague that I was having a discussion with, a neurosurgeon who, like myself, has worked in different countries, and now he's based in the US. And he was telling me, I think the overall healthcare system in the US has very high quality, but offers very low value for patients. And I, looking from the outside in, I tend to agree with that statement. If you go to the top institutions and pick the top pain physicians or surgeons or whatever area you want to work at, probably the US has 8 out of 10 or 7 out of 10 of those top people in the world in a specific area that whatever area you want to work on. But then something happens within the system that the value that is provided for the patient gets lost in the middle of so many transactions and so many middlemen.
I tend
That is my view.
Um, I agree with that. Of course, it's so fragmented. I mean, I've seen like I've seen, so much, some people get the best care of the world and the worst care of the world in the same hospital, setting. So it really depends on where you go for what problem. But one of my biggest problems with the healthcare system here with respect to pain management is I feel like we're so restricted, meaning if your hip, knee, and shoulder hurt you and you come to a pain doctor in the States, the chances of getting all three of those problems addressed in a timely fashion are very small, meaning the first visit, you may or may not be able to do a shot. There's a good chance you won't be able to do, if they come to you for a knee problem and then you want to do a knee shot on the same day, Medicare will not pay for both the visit as well as the injection.
Okay.
Now, if you wanted to get a trigger point with your knee shot or an epidural with your knee shot or some other procedure, they still will not pay for more than one intervention per day, generally speaking. And most private payers, they follow suit. So what happens is the care gets drawn out over the period of weeks because you have to get authorizations or you have to have separate visits to separate everything to avoid getting a denial, and you don't want the patients to get bills because they get angry. But when I went to visit the Canadian clinics, well, these doctors could take care of everything on the first day. So while their patients may wait a year for an MRI or for a surgery or even for an epidural if they live in remote places, they can get a trigger point, knee injection, epidural all at once if that was what was indicated. So,
So in Europe, it would be um, a mix of both. I don't like to say Europe in general because Europe has a lot of different
sure.
systems. But for example, in Barcelona right now, if you come to me and I have to get our authorization from your health insurance to be able to do a procedure, it would be somewhat similar in that I wouldn't be able to do three procedures in the same sitting. I might get away with doing two of them
Mm,
and be able to build both procedures, but I wouldn't be able to build three procedures, for example. So two would be the max. But it is true that I'm getting more and more patients who would rather just pay out of pocket. And so obviously, if you're paying out of pocket, I'm able and free to do whatever you and I agree that would be the most reasonable option for your care on one sitting. Um, I wouldn't also be a big fan of doing, say, three procedures in the same setting, but two procedures, I'm okay with that. And so I do have a lot of patients who are paying out of pocket, and they just come into the office. They have a bad hip, a bad low back,
sure.
and a bad shoulder, and so we start by whatever bothers you the most, and then we take it from there. So if your hip is the main issue today, along with your shoulder, then we'll try to address the hip and the shoulder today, and then we'll do the low back in 2 or 3 weeks, for example.
Mhm.
So I'm able to reasonably address most of my patients' issues in a matter of a month, I would say. 4 to 6 weeks, I would say, which in chronic pain, although not being ideal, I would say it's reasonable.
Right. And then, I mean, the whole thing with the regenerative medicine, because it's purely a cash procedure, um, I find it's a lot easier to treat people because you could do everything at once right then and there. Um, I guess my next question relates to the fact that I have an office in which I don't have an X-ray machine in. So rarely, usually I don't do this, but every now and then, and I'll wind up doing an ultrasound-guided PRP spine intervention. Have you ever done ultrasound-guided PRP spine interventions, or are you strictly using the X-ray machine for this?
I'm almost 100% using ultrasound. And again, I
Ah,
get a lot of pushback because I don't have any contrast, so you're not able to tell me 100% certainty that your shot was where you believe it was, and I do the same thing, and I get a lot of pushback because of that. But I stand my ground, and as long as
I am
people
with
let me
you.
uh,
First of all, contrast,
use
in my
ultrasound.
opinion, is completely overused. Um, Especially if you're, all right, if you're injecting PRP, what if you accidentally inject into a blood vessel? It's PRP, it's blood. It's not going to kill the patient. Um, and as far as accuracy goes, you might not know your level as well, but you could, so there are ways to find your level. But um, when I had my own neck issue, I had one of my students at my course give me the PRP under ultrasound and the extraforaminal space in the neck, as well as around the facet joints. And it helped me so much. I mean, more than the steroid shot I received prior to that. So the way I look at it is if it's something I'm putting myself or a relative through, it's ethical and it's possibly best care. And that's why I would advocate for my patients.
So to me, in the cervical spine, it's a no-brainer. Ultrasound is much safer, and it is as effective as anything you can try to do with X-ray, except if you want to do an interlaminar, of course. But outside of doing interlaminars, anything in the cervical spine, if I'm having a shot, I'd want it under ultrasound for sure, and I want to have
I
the
gotta
shot by
stop you.
someone who's. Yeah, yeah, go
I
ahead.
gotta cut you off because you're possibly the first person I met. So if somebody comes to you with a cervical radiculopathy and they failed all conservative care, you're not doing a cervical epidural. You're first doing an ultrasound injection.
Correct. My first option would be an ultrasound-guided extraforaminal selective nerve root block.
Thank you, because you're the only person that I think I know that does that. And I do that too. I've been advocating that for years, and in the States, I think just because of the way the training is, and the fact that pain physicians are not paid to do an ultrasound selective nerve root block here. In the States, it's a T code, which is an experimental code. It's been
Gotcha.
it's been experimental for 15 years. And I mean, for 15 years, I've done either a suprascapular nerve block or an extraforaminal selective nerve root block. And I bill it as a brachial plexus block because they pay for brachial plexus. And I don't think
Mhm.
it's fraud because if you look at any anatomy book, the roots are part of the brachial plexus. So that's how I could do it and get paid for it. But many people are not aware of that and therefore are not doing that. And they're doing cervical epidurals. And I believe it's way more invasive than necessary.
The research has been out there for, I want to say, at least 10 years. Samer and Naruse has a lot of his papers showing that extraforaminal selective nerve root blocks are, safe and as effective in most circumstances as a cervical interlaminar or even transforaminals would be. And so if you have a procedure that is, from my perspective, safer than the two other alternatives in which you see blood vessels directly in real time under ultrasound. I see uh, all of my needle path, so I know exactly if I'm close to a vessel or going through a vessel. I see in the real time where my medication is going. So to me, that is 100% safer than any other alternative. Now, if that doesn't work, do I use X-ray? Yes, of course. I still use X-ray. I still do my cervical interlaminars. I do the standard contralateral oblique, like everyone does. But my first option would be under if it's a patient who has four level compression on the cervical spine, and it's hard to know if what dermatome the pain is because it's very diffuse. It might be from two or three different dermatomes. And for that patient, maybe an interlaminar would be my first line treatment. But for a patient who comes in with your typical C5, C6 disc herniation with a very clear C5 or C6 dermatome pattern of pain, no doubt my first line of treatments would be an ultrasound-guided extraforaminal selective nerve root block of the C5 or C6 or both in the same sitting. And I've been doing that for at least 3 or 4 years with very good results.
You're using
Now,
X. Dexamethasone and local anesthetic, or
Correct. Yes, always DEXA for obvious reasons, non-particulates,
right.
and a little bit of local. Now, in the lumbar spine, it is true that, obviously, I'm very ultrasound centric, and I dedicate my research and my career to ultrasound. But obviously, if I have a patient who comes into the office with a BMI of 40 or 42, I'm
Sure.
probably not going to do, lumbar facets under ultrasound. Obviously, we're talking about, patients who come in and their low back hurting, and we want to check if it's a facet syndrome or not, and their BMI is 25, 30, maybe 31, 32. Obviously, if you get patients with a BMI over 35 or 40, which again is much more common in the US than it is in Europe, today, maybe that will change in the future, but as of today, it's still more common. Then obviously, there's no way, even if you have the best ultrasound equipment out there, you won't be able to properly do lumbar facets in ultrasound and that high of a BMI.
So in Spain, do they pay you to do the ultrasound spine work? Like, is there a code that they actually reimburse?
Yes, it's the same thing as under fluoro. So you're free to choose whatever you feel is more is the most adequate way of doing the procedure.
Our system is so antiquated that our coding system will tell you fluoroscopy or CAT scan, and they neglect to include ultrasound for these
Ultrasound.
for anything, for SI joint, for epidural. During COVID, I was doing a lot of ultrasound epidurals because I couldn't bring patients into the fluoroscopy suite if they didn't have a vaccine, or the COVID status, this or that. So we would do them in the exam rooms. But Medicare clearly came out saying you can't do an ultrasound epidural unless they're pregnant, and it's a shame. Um,
So for example, to me, let's say I have a patient with a possible sacroiliac joint pain, and I want to do a diagnostic shot to make sure, is it sacroiliac joint or is it something else? So I put a code of a sacroiliac joint block, and that's it, and I get billed for that block. Whether that takes me half an hour under X-ray or 2 minutes under ultrasound, or the other way around, I get paid the same thing.
Amazing. Yeah.
So that is an advantage to, in my perspective, yes.
Sure. It's nice to hear this. I discovered this sort of accidentally in 2000, I think 8 or 9. I was transitioning from anesthesia to pain. I didn't have a C-arm for about 6 months. So people come in with cervical ridic and they're touching themselves over here. So I started doing suprascapular nerve blocks in the brachial plexus or selective nerve roots, and they did great. 90%, never needed an epidural, never needed to go to surgery. So I've been advocating that ever since. But it's the limiting factor is truly the payment structure in the States, and it's really a sad thing that too many epidurals are being done.
So I've even I do that less now, unfortunately, because I really like that. I really like that part of my job. I used to work with a neurosurgeon who would send whenever they were in doubt in doing 1 or 2 or 3 level decompressions, cervical. I'm talking cervical spine. They would send me the patients, and I would do serial extraforaminal guided blocks. And then over the course of 3 days, each day I would do one block. So today I would do C4, tomorrow I would do C5, the next day I would do C6. And then we would look at the pain charts of the patients for those 3 days. We would see if he or she had over 50% pain relief from C4, from C5, from C6. And then let's say the patient only had significant pain relief from C5 and C6. Then I would send the patient back to the surgeon, and the surgeon would only decompress C5 and C6, and they would leave C4 alone.
Amazing.
So that was an amazing collab that I had with the neurosurgeon, and
They
it worked really well.
here. That wouldn't work here.
It wouldn't work really well. I haven't done that as much for the last year, but that was a collab that I really enjoyed, and it was amazing for patients.
And you were using purely ultrasound, no X-ray, to tell the
Purely
level.
ultrasound, yes. That was purely under ultrasound.
So when you're telling the level from the ultrasound, are you using Chasser-Nagg's tubercle as the main landmark, or are you just looking at the
if it is a patient with a relatively slim and tall neck, I usually count in the sagittal plane, and I start in the mastoid, and I count my way down, and then I pick my level. If it is, and then I just move to axial, I change to axial, and I go a little bit anterior, and I do the corresponding level. If it is a patient with a relatively fat or short neck, then I start from C7, I find C6, and then I go from C6 to C5 and C4. Now, in short and fat necks, it is relatively hard to count above C4 in my experience. So anything from C4 to C7, C8, I'm relatively comfortable in doing under ultrasound. If it is something C2, C3 in a very short or very fat neck, sometimes it can be very tricky. If it is a long and thin neck, you can do whatever you want to do. But in those easier patients, I typically go sagittal right over the mastoid. I come down, I see C2, TON, and C3, and then I just go down slowly. I pick my level. So, I count the peaks and valleys of the facet, and then I turn to axial, and I go anterior, and then I see my nerve root.
That's great. That's great. Yeah, I wish we had the freedom here to do that sort of thing, but still, yes. I think ultrasound is the way to go, and ultrasound is here to stay. Um, anyway, I think I have to get my day started. I have patients coming in soon. Yeah, I wanted to thank you for being on the show. Is there anything you'd like to just mention in closing, about your practice or what you
Um,
do?
I mean, not really. I always enjoy talking and meeting and speaking to fellow ultrasound enthusiasts. So thank you very much for having me on the show. It was a pleasure to talk to you finally, and really looking forward to meeting in person in Dubai in Pain Expo. So if you guys want to come down to Dubai in April, we'll have a chat.
Thank you for coming and being on the show. Dubai is going to be fantastic. It's not just the two of us; it's a whole international group of world-renowned pain physicians, and it's going to be a lot of fun. So try to check us out. And thanks for listening. Thanks, Guy. Have a happy
Thank
New
you.
Year.
Bye bye. Happy New Year. Bye bye. Bye
Take
bye.
care. Bye.